most of this material you've heard several times, and as you already know, there is a marked increase in obesity in this country. You've seen it slide after slide after slide. Obviously, it's all correlated with increased coronary artery disease, myocardial infarction, strokes, et cetera, et cetera. That kind of goes without saying. This is a slide that was also presented once before, and the bottom line on it is 22% of Americans have metabolic syndrome. That's 47 million. Obviously, it's a major problem. I don't know about your practices, but probably, well, I do a lot of weight and wellness, so probably the majority of the patients that I see have metabolic syndrome. A lot of people think, obviously, it has to do with insulin. As you, I mean, it's not really insulin itself. As you know, the cardiovascular risks are determined by the degree of insulin resistance. And I'll talk a little bit about that. And the lifestyle factors, again, you already know the lifestyle factors. The high glycemic load, the high saturated fats, trans fatty acids. Exercise is a big problem. This is some of the definitions of metabolic syndrome, and I'm not really a researcher, I'm a clinician, so basically I don't use a lot of these. As you know, hypertension, dyslipidemia, obesity, increased body mass, remember over 25 is overweight, over 30 is obese. The waist to hip ratio, hyperglycemia, it's extremely controversial, and it goes on and on and on. It's, WHO is trying to change it, as I noted here, with adding microalbuminemia as well as C-reactive protein. These are all the people that are involved in trying to determine what the parameters are. The bottom line is, in the real world and in practice, the bottom, despite all the variations and definitions, the most consistent marker is a waist size above 40 inches. When you see that patient come in, that gentleman that has a waist size of 44 inches and his sugar's up and his pressure's up, he has metabolic syndrome. That's a real easy one. Again, the incidence, you already know that. We went through that. It's 47 million adults. 60% of the U.S. population is overweight. It's in epidemic proportions. I think that's what this whole conference is about. You notice a lot of these articles, or a lot of the talks that we're going to be hearing are about obesity and metabolic syndrome. Everyone loves this. I was surprised. Florida did pretty well, 23%. That was great. But I do think we should move to Colorado. Looks great. I just came back from there. This is what my patients look like. Most of them. Actually, I saw one yesterday that was just broke 600 pounds, and he's a little bit bigger than that. The pathogenesis of metabolic syndrome, insulin resistance, endothelial dysfunction. You're going to hear that from now on throughout the conference, and it's extremely important. And inflammation. As you know, there's a paradigm shift in this country towards inflammation causing cancer, causing all the problems, heart disease, and certainly metabolic syndrome. First, these are three views on insulin resistance. The first view is that it's a polygenetic disorder because they have seen this in children, as our previous speaker had discussed. They've seen that they developed this dyslipidemia, hypertension, and hyperglycemia prior to developing the insulin resistance. So there are some schools of thought that say that this is polygenetic. If you've ever seen those family pictures where people come from all over the country and everyone is about 250 pounds, well, that speaks to polygenetic. I mean, that's a possibility. But I think that you get into the old argument of environment versus heredity. So supersize me. It's interesting. I have a couple slides that have to do with McDonald's, and today is the beginning of the McDonald's conference here at this hotel. Unlike the subcutaneous tissue, adipose tissue is visceral. Adipose cells produce significant amounts of pro-cytokines such as tumor necrosis, interleukins, and I think you're going to hear a lot of people speak about that. Actually, my partner, Dr. Gloria Hakkarainen, is going to be speaking this afternoon. She's going to speak more to that and more to a lot of these pro-inflammatory cytokines. But these pro-inflammatory cytokines disrupt the insulin action in fat and muscle cells. And so this is another way of trying to define this problem. And third, the visceral adiposity. This is fairly, in the last few years, you hear more and more people talk about the non-alcoholic fatty liver disease. And as you can see, that's another possibility, increasing the hepatic glucose production. And they both do have a profound effect on peripheral insulin resistance, increasing the likelihood of type 2 diabetes. I don't know if you saw it on that one picture I had there of the MRI, but that gentleman had a lot of visceral adipose. Endothelial dysfunction, primary importance and pathogenesis. I mean, obviously, we know that also. Dyslipidemia, hypertension. This is kind of interesting. You know, we really don't pay that much attention to this vascular endothelium, but it is the largest endocrine organ. That sounds like one of those board questions. Surface area of 14,000 square feet, metabolically active in endocrine, paracrine, autocrine, and intracrine. Those are what? Endocrine is secreting, paracrine is cell-cell information by a closed cell, autocrine is where it comes back to the cell, and intracrine is intracellular, such as steroids. The endothelial lining is activated by biochemical and biomechanical. That's something that's a little different. And most things in the body are activated by biochemical, but biomechanical is a little different. And of course, it can cause a secretion of these multiple substances. Inflammation. We talked about inflammation, the adipokines, the IL-6, tumor necrosis factor, causing a subsequent rise in C-reactive protein. You know, the C-reactive protein is a screening tool. I really don't use it that much. Some people say they use it, but there's so many things that can cause inflammation, from an inflammatory diet to heart disease to metabolic syndrome. So I don't find it as a reliable marker. These substances at the bottom, resistin, these are all hormones secreted from fat. Resistin is one of those cysteine-rich type of hormones which injected causes insulin resistance. Lots of studies going on. The ASP stimulates triglycerides. Adiponectin is inversely proportional to the amount of fat, and so on and so on. And you've heard them talk about leptin. Leptin and resistin both are proportional with the fat, by the way. Adiponectin is the one that's the opposite.